Oh, here we go. We see the numbers going up. I was like, I'm not seeing anyone. Give me 1 second. Haley, should we start now or should we just wait like another minute or two?
I would give it just about 1 more minute for everybody to join and log in.
I've never been on this end of the webinar, so it's like, this is a little strange.
I know, me
I'm
too.
just saying, Jessica, it's like a conversation between the two of us. Anyway. All right. All right. Why don't we get started? So to everyone here on the webinar who I cannot see, I want to thank everyone for coming today. And it is my pleasure to introduce Dr. Jessica Ridgway. So Dr. Ridgway is an associate professor of medicine in the section of infectious diseases and global health and director of medical informatics at the University of Chicago. She is director of predictive analytics for the Chicago Center for HIV Elimination. And her research focuses on utilizing large electronic medical record databases to understand HIV epidemiology across the continuum of care and implementation of clinical informatics interventions to improve HIV care and prevention. And just as a side note, Jessica and I used to kind of work together at the University of Chicago in the aforementioned Chicago Center for HIV Elimination, and we also share a mentor in common. So Jessica, it's a pleasure to have you here, and I'll let you take it away.
Great. Thank you so much, Lindsay. Thank you for inviting me, and I'm really looking forward to chatting with you all. So I will share my screen. Okay. Great. So the title of my talk today is Predictive Analytics for Retention in HIV Care. And I wanted to share a few disclosures, just the funding that I've received. Okay, so for those of you who are less familiar with HIV and sort of how we think about the HIV epidemic in the US, I wanted to start with a little bit of background. So in the United States, one way that epidemiologists think about HIV care is through the HIV care continuum. And so that's the idea that of, all people in the US who are living with HIV, 100% of people, there's a certain percentage that are aware of their HIV diagnosis, so they've been diagnosed. There's a certain percentage of those that are in care, so they're regularly seeing a provider who's, prescribing them antiretroviral therapy, taking care of their medical needs. And then there's a certain percentage of those or people who are virally suppressed. So that basically means that if you have HIV that's untreated, your viral load can be very high. That's it's a blood test, it's in your system, but it can be suppressed to where it's undetectable if you're on antiretroviral therapy. And so currently in the U.S., 86% of people have been diagnosed. Only about 50% receive regular medical care, and about 58% are virally suppressed. And so definitely well below the goals that we have for public health. Ideally, everyone would be diagnosed, everyone in care, and everyone virally suppressed. And so retention in care, when I use that phrase, I'm talking about the people who are receiving regular medical care and are in care. So why is retention and care important? So there have been, multiple studies looking at this, and we know that people with HIV who are retained in care, who are getting regular care, they're more likely to get antiretroviral therapy. It's associated with a whole host of improved health outcomes at the individual level. There's a decreased risk of mortality, like irrespective of taking antiretrovirals and other things. So it's really important for folks' individual health. But then also from a public health perspective, it's also important. There's this, there's this phrase we use, undetectable equals untransmittable, and it really is, become sort of a cornerstone of public health practice and messaging around the world. That basically, if someone with HIV is able to get to an undetectable viral load, then they are no longer contagious. As long as they stay on antiretroviral therapy and stay undetectable, they are not going to transmit HIV to other people. And so, retention and care is really important for individual health, but also for public health, to prevent the onward transmission of HIV. And then, the other thing is, there is a lot of focus, and rightfully so, on identifying people with HIV who are not aware of their diagnosis, right? They don't know they have HIV, they've never been tested. And so there's lots of HIV testing programs. But actually, it's the people who have been diagnosed with HIV but are not receiving regular medical care that actually account for more new transmissions of HIV in the US. So if you look, if 15% of HIV, 15% of people with HIV are unaware of their status, and they account for 38% of new transmissions, but it's the 23% of people who have been diagnosed but aren't in care that account for 43% of new transmissions in the US. So this is definitely a group that we really need to give more resources to, and should do more effort, in our HIV clinics and from a public health perspective, to try to get them, re-engaged, retained in care, to prevent onward transmission and for their own health. Okay, so how do we improve retention, right? So we know it's a problem. We know that people need to be retained in care. We know that a lot of people are not retained in care, half of people in the US. So what can we do about it? So, clinics have tried various things, like just appointment reminders can help a little bit, right? Like getting a text message or a phone call from your doctor saying, you missed your appointment, or you're due. Patient education. Sometimes a lot of it, even like intensive case management. So having a case manager or a peer navigator or someone who can, go with the patient to their appointments and, make sure that all their needs are met if possible, whether it's housing, substance misuse, psychiatric help, assisting with other resources, transportation, patient navigation. So, sort of similar to that, or peer mentoring, having, someone have a peer, come with them, or someone else who is living with HIV sort of mentor them, or even, having outreach workers or home visits. So it really runs the gamut from, really low touch, just like a reminder, to like this really intensive, intervention to try to improve retention. So, the issue with a lot of these is that, first of all, many of them happen after patients are already out of care. So, someone already missed their appointment, or someone is there in care, and then, they don't make a follow-up appointment and then just don't come back, right? And it's really hard. A lot of our patients, after they've, disengaged from care, it's really hard to find them. People change phone numbers. They might not have unstable housing. And so it's hard to identify them. And then, at least in Chicago, our Department of Public Health tells us that 91% of our patients who are out of care have been out of care for more than 2 years. And so it's even harder to find them. And it's a really long time for them to be out of care, right? Ideally, you would, get in touch with them and relocate, get them back in care pretty quickly. And then also a lot of these, interventions I mentioned are, pretty resource intensive, like going to someone's home, getting a case manager, like, we really can't with the resources, the US health system, it's really would be difficult to give that to everyone who needs it or to everyone, without knowing if they're going to need it or not. And so that's all of that is really the impetus behind this work that I'm going to talk about today, which is, using predictive modeling in order to predict each patient's risk for falling out of care before they fall out of care, and to see if we could, use that to try to improve the continuum of HIV care in the US. So the idea really is that, we could potentially have like a real-time individualized assessment of risk. And we could use that, when the patient is, in clinic, or, at the time of diagnosis to try to target our retention resources to folks who are really at the highest risk of falling out of care or lapsing in care. And so with that, I'm going to go through a few of the studies that we've done to do some predictive modeling around this issue and sort of present some of our findings. I'll also talk about, some of the challenges we've run into with this work, and then, to finally talk about some of our future directions. So excited to share some of this with you. So the first study we did is that basically we wanted to create a predictive model of retention and care using electronic medical record data from the University of Chicago HIV clinic. And so our clinic, we're located on the south side of Chicago in an area with a number of neighborhoods around us have pretty high rates of HIV, rates of poverty, violence, and, are traditionally underserved areas. So we took EMR data, we took some electronic contextual metadata, and then used a few different machine learning methods to create this model. So again, this was all, so there was all the EMR data that we could get for our patients from our clinic. So this included, the appointments. And so we had, whether they scheduled the appointment, whether they attended the appointment, whether they missed it or canceled it. Not only in the university, not only in our clinic, but in, all other clinics at University of Chicago too. So say they had like an appointment in cardiology and they missed that, we took that data as well. We took into account all the different diagnoses that were present, in the billing codes, the problem list, past medical history, their social history, their laboratory values, so including like their viral load, like were they suppressed or not, and their CD4 count, so that, for folks with HIV, that's sort of an assessment of their immune function. Whereas, with folks with well-controlled HIV have high CD4 counts, and if they don't, it could be low. And then we took into account like their medications, their antiretroviral therapy prescriptions and pill patterns, the pill burden, like how many pills they had to take as part of their HIV regimen and other medications. And then just like basic demographics and insurance information. And then we also geocoded their addresses. And so these maps sort of show, so University of Chicago, I don't know if you can see down there, but it's the little like pink cross, that's our hospital. And so you can sort of see, we looked at the sort of the density of our patients. A lot of them come from neighborhoods around us, but some further away. And then we looked at like their travel time by car, how long it would take them to travel by public transportation, and then also like the crime rate along their travel route to see if that might also influence things. Then we included data from American Community Survey, and so y'all are in Chicago, but in Chicago has this this open data portal, which is like basically a publicly available data with information by neighborhood area, where they include all sorts of different data. So they have like like how many calls there were for potholes on the street, or but then also basic crime information, and just basically all sorts of levels of data that could be reported to the city or that the city keeps track of. And then we included, neighborhood characteristics like average income level, education level, the racial ethnic composition, and the crime rates, as I mentioned. And so in terms of our outcomes, so, retention and care, is sort of this, a general concept is like getting regular care, right? But there's actually several different definitions of retention and care. So the ones that we used for this study, so one is the HRSA, is the health and human resource. I can't exactly remember what HRSA stands for off the top of my head. But it's the U.S. Agency has a definition where they basically mean that you're retained in care if you have 2 attended HIV visits within a 12-month period, more than 90 days apart. So that's to basically mean that showing you have regular visits. Oh, the Health Resources and Services Administration. There you go. The HIV/AIDS Bureau. So you have 2 kept visits more than 90 days apart within a year. Or another outcome measure we looked at is the basically called the 6-month gap outcome measure, and you're considered retained if there's no more than 6 months between sequential kept visits in a 12-month period. So we looked at both of those outcomes, which kind of they're measured pretty similar things and they're really correlated. And then in terms of the different methods we used, and this was done in collaboration. I will give, a little bit of a caveat. I myself am not a computer scientist and did not do the machine learning analyses, but my collaborators in our computer science department did. And so we looked at decision trees, random forest, logistic regression, and gradient boosting. And we used temporal cross-validation for validation. And we chose to make the predictions at the appointment level. So we didn't do it at the patient level, but we did it at the encounter level. So basically, like, when this patient is in front of you at the appointment, what are their chances of being retained in the next year? And then we compared the precision of each model to a baseline retention rate, and to like a simple logistic regression model, which was meant to simulate kind of like an expert heuristic model. So basically being like, to sort of how a provider would think, basically like, were you retained in the last year or not? And like, what's your viral load? And so that was sort of our simple model. So these are the patient characteristics. So we did have 713 patients, 56% male, majority African American, a lot of them with Medicaid or Medicare, average age around 47, and you can see some of the other factors here. And these were the results. So this graph shows the positive predictive value of the highest 10% of risk scores for retention and care. So these are the people who were at greatest risk of falling out of care for the top 10%. Thinking that if our clinic maybe would have the resources to really focus on 10%. And so that's why we chose that cutoff. And you can see, it's sort of the positive predictive value is, the highest one for the HRSA-HAB definition was our random forest model, which, sort of hovered in around, 25-30%. And you can also see the decision tree, the previous state of the art. That's just the simple model. And then this is for the 6-month gap measure. And again, like the random forest, the logistic regression model did pretty well too, but the random forest performed the best in that assessment as well. In terms of the most important features, because I think, especially for clinicians, I think it is important sometimes with these machine learning models for us to be able to say like what features were important and does it make sense to them, right? And so the most important one by far was previous encounters, right? So like if you had attended appointments before, you were more likely to keep attending appointments, right? Like that makes a lot of sense. And then retention history. So again, if you were retained before, you're more likely to continue to be retained. And then also viral load, the actual provider, like which provider you saw, and then a few, a number of other factors that all kind of made sense. So that was, a study we did, just with our University of Chicago data to see if we could come up with this model that we could use at our clinic. And so then we thought, it would be nice to see if we could do something similar, do a predictive model with data from other centers as well. And so we did another study using data from 8 medical centers that are part of the Centers for AIDS Research Network of Integrated Clinical Systems. And so this is like a research network where they have, folks with HIV agree to be part of these research studies at these 8 different medical centers around the country. And so we included, all adult Phoenix participants, who were basically seen between 2007 and 2018. And then, for them, we didn't have sort of the whole like messy electronic medical record. But we had the data that was in the database that they collect for CNICS. And so that was 177 different variables that were available to us. But it included things like demographics, past history of retention, transmission factor, like how folks acquired HIV, labs, diagnoses, and antiretrovirals. And so for this study, we did the HRSA-HAB outcome again, and then we also looked at 12-month gap, and that was based on feedback from those centers saying that a lot of their patients weren't necessarily seen every 6 months, but even up to a year was acceptable, and so we chose the 12-month gap to be a little bit more inclusive. And for this study, we split the data longitudinally and used a discrete time survival analysis framework. And we compared our baseline logistic regression model, which was, another like sort of simple model with just, past visit history, viral suppression, and patient characteristics, with a more complete logistic regression model, random forest, and gradient boosted machine models. And these were the characteristics of the patients. So this is based on their first encounter, whether they're retained or not retained. Retained in the first column, not retained in the second. You can see, in this, it was sort of a different patient population than ours. So definitely more predominantly male, less, it was more, less African-American or Black folks, with a majority white. And then you can see, and a little bit younger than our patient population, so mean age of 40. Then you can see how folks acquired HIV there. And so these were, and then calculated the area under the curve for the different measures. And our, these results, they were okay. Again, like our prior, model where it was like the positive predictive value was like 30%, like better than nothing, but not like great. The AUCs for these models were, we got as high, like the XG boost was, 0.69 for the 12-month gap measure. And for the HRSA-HAB, the best was the random forest with 0.6. Better, a little bit better than the baseline, but not, not remarkably so. And these were the variable importance that we found for the logistic regression model for the 12-month gap outcome. So age was important, the viral suppression in the last year, retention history. So similar, we had similar findings really. It's like a lot has to do with your viral load, your retention history, some stuff around STIs, like folks who, had like the number of STIs in the last year, or like patterns related to syphilis testing. So, we sort of, I think this was an interesting study because we really wanted to see, at multiple sites, and I thought it was interesting, our logistic regression model was better than the baseline, but there really wasn't that much improvement with these like more advanced machine learning models. And, the performance of our models was not that great. And, it's sort of, I think indicative of the fact that we were bringing in, such a diverse patient population from like so many different centers, that it, really didn't work as well, as the one that was like more internal to us. So speaking about, I wanted to share some, cautions. I don't know how many of you have worked with electronic medical record data before, but they're really, I think it's important to know sort of some of the shortcomings of the data, when you're using it, right? And so there can definitely be incorrect documentation. So a lot of our diagnoses are just based on billing codes, ICD-9 or ICD-10 codes that providers or like billing departments put in, and people, can definitely put in the wrong codes. If you're just testing for diabetes, sometimes people will code it as like having diabetes. There's also a lot of missing documentation, especially around sexual orientation and gender identity. At University of Chicago, we just recently had a big push to increase documentation around that. But it's still not great. And like a lot of centers, don't do that routinely. There's missing documentation around substance use, about psychiatric health, a lot about other social determinants of health, measuring, whether people have food insecurity or whether they're safe, which all can really impact HIV care, right? And retention in care. Those are the main things that contribute. And if they're not in the electronic medical record, you're not going to be able to include them in any model, right? We tried to get at some of that with some of the neighborhood level characteristics, but I think you're still missing some of that individual level information to the extent that it's not in the electronic medical record. Just identifying people who have HIV in the EMR data can be difficult. So sort of like, how do you even determine someone is HIV positive, right? So you could look at lab data, but, an HIV test is actually a two-step test. So there's a screening test, and then if that's positive, it goes on to a confirmatory test. And sometimes those two tests, like when you get the data, they're uncoupled from each other. And so you just have the screening test and you don't have the other, the confirmatory test. And so how do you, you'll get wrong data if you count any screening test as positive, right? People could use ICD codes to say someone has HIV, but again, those might be incorrect. Someone just being tested for HIV, the provider might document HIV accidentally. Or medication data, right? You could say like if someone's taking antiretroviral therapy, they probably have HIV. But now that we have PrEP, pre-exposure prophylaxis, which is antiretroviral therapy, some of the same medicines we use to treat HIV are now given to prevent HIV, or post-exposure prophylaxis. So if you were exposed to HIV, you can take antiretrovirals to prevent yourself from getting it. That can really muddy the water to distinguish, which antiretrovirals are prescribed for HIV versus to prevent it. I next want to present a little bit of data from the Chicago Area Patient-Centered Outcomes Research Network, or Capricorn. So this is a clinical data research network that has linked data from EMRs for over 10 million patients from different healthcare systems in Chicago. And they deduplicated the patients via this hashing matching process. And it's kind of neat because it includes academic medical centers, but also community hospitals and clinics. And so we wanted to look at this data to try to identify patterns in HIV. But our first test was, how do we even know who has HIV, right? So we looked at who had a positive HIV lab test, and that's in the red. You can see like those are the number of people in the Capricorn database who had that. Then the yellow shows you who had an HIV diagnosis code, like an ICD-9 or ICD-10 code. And then the green shows how many were prescribed ART, like an HIV specific medication. And, there's some overlap, but there's a lot that is not overlap, right? And so do all of these people have HIV? Like we can be pretty sure about, that 8,576, right? Where, they have all three. But what about the folks who only have one of them? Other people have looked at this. So this was a study by Paul and colleagues that they was published in JAMIA in 2018, where they developed these algorithms to try to identify people with HIV. I think it was based out of somewhere in North Carolina, like sort of looking at, how do we, and they like did chart reviews to try to see, and they basically, started with an HIV antibody test and, went through this whole, algorithm of if the PCR, so that's the confirmatory test, is positive or not. whether someone's on HIV-specific medications, and basically found that this algorithm had sensitivity of 78%, but highly specific at 99%. And then they took another algorithm where they started with the diagnosis code, and then they went to like whether they had a test or not, sort of with the medications, and again, about a 77% sensitive, but highly specific. So we took their algorithms. Oh, sorry. I'll get to that in a minute. But so basically, the most common reasons. So they're really specific, but they're not that sensitive. And the main reasons they missed people with HIV was that there was missing laboratory data, missing medication data, or the patients were diagnosed with HIV at an outside institution. And I think, that, definitely happens, until we have, fully interoperable, electronic medical records where everything is, shared and people can get data from other health systems. There's definitely going to be missing data, right? And so you're going to miss some people. So we took their algorithms and adapted them a little bit to see if we could use them to identify people with HIV in the Capricorn database. And it was a fully de-identified database, so we weren't able to do chart reviews to see who actually has HIV or not. So we thought we would start with the Paul algorithm and develop these different sort of algorithms, but also included criteria around having a diagnosis code for HIV and having multiple HIV viral load tests performed, with the idea that, if someone has HIV, but they're virally suppressed, they'll still have their provider draw the viral load and it'll come back suppressed or negative, but that might be someone who, is doing well and on chronic antiretrovirals and suppressed. And so we included that as an additional criteria, and you can sort of see the different criteria there for our algorithms. And these were our results. So the first algorithm, you can see it was the red. The most inclusive was algorithm 4. And we're not entirely sure again which one of these are right, but based on the Paul study, at least they're probably highly specific and about 75% sensitive. And again, you can sort of get a different number of people depending on which algorithm you were looking at. Okay, also related to pitfalls in EMR data for HIV is that there's often really under documentation of social determinants of health in the EMR. So we actually had a medical student do a study where he surveyed our patients in clinic and screened them for depression, anxiety, and substance use, and found really high rates. So 33% had depression, 22% anxiety, 54% substance misuse. But then he went and looked to see if these were even documented in the EMR. And they were very rarely reported, which shows we need to do a better job of screening in our clinic, but also a better job of documentation. And so we actually developed some NLP algorithms in order to try to identify mental illness and substance misuse in our clinic. And I'll, spare you the details, but we published, the algorithms we used to basically, they were pretty simple. They was like looking for keywords, getting rid of negation, with these natural language processing algorithms, and actually found, pretty high positive predictive values and negative predictive values for these algorithms to see if we could, potentially improve the detection. Because a lot of times it's, we realize that the provider is actually aware of the diagnosis and has written stuff in their note. They just don't document it in as a diagnosis or in the structured fields of the electronic medical record. They just write it in their note. And so that was the idea that, we thought that if we could use natural language processing and really get at the text of the note, we can, better elucidate some of these features. And so these are the results of the study, sort of looking at trying to identify mental illness in these people with HIV, and sort of you can see the different places where it's documented, right? So the NLP of the notes versus in a diagnosis code versus in the problem list, which is a different, section of the medical record. And a lot more were in, the NLP of the notes than were in the other places. similar with substance misuse. And we also looked at social history for that, because that's like another section of the medical record that that providers will document. So, we thought it was pretty interesting that like in patients with mental illness detected by NLP, only just over half had documentation of it in at least one structured medical record field. And similarly, among patients with substance misuse, 73% had documentation in at least one structured EMR field. More than half, but still, like, we could do a lot better. And you're going to miss this if you're only looking at the structured fields for your predictive models. And so then we did a study where we thought, well, maybe to predict retention and care, we should just get rid of the structured data. And what if we just use the natural language processing of the clinical notes to try to predict retention and care? And so this we did we basically took all of our clinical HIV care notes from our clinic, looked at the outcome of 6-month gap, and developed a predictive model of retention and care using NLP of the notes. We tokenized and lematized the notes. We got rid of negations, and we categorized. It was really like a sort of a supervised process. We categorized words and phrases, that we thought would be relevant, sort of in different domains, and then did a supervised machine learning pipeline. And classified notes as either, belonging to patients who are retained in care versus not retained in care. So here, in the end, there were 7,000 notes among 791 patients. And so this figure sort of shows the process we went through, and again, sort of showing sort of the different negation process. We got rid of, if someone said like, my brother is depressed, we sort of got rid of words that were around, family members. We found that, in doing some, chart reviews that was where we were, falsely assigning depression to a note, and developed our model. So these are some of the results. So we did 2 different experiments, sort of. So the main one, where we basically took the first, the first note for the patient, and if someone was retained or not, we just like kept the notes that were associated with retention. And then in the keep all notes one, we kept, we basically included all the notes, whether the patient was retained or not. And so, the tricky thing with this sort of modeling is that patients, don't have just one outcome, right? People can be retained and then not retained, and then retained and retained and then not retained. And so for the keep all notes, when we included everything and, sort of didn't throw out any other additional notes. So that one's sort of more really speaks to sort of a real life scenario, whereas the sort of the main experiment there was where, again, we just looked at sort of their first outcome and kept the notes associated with that one. But you can see, so we predicted both retention and loss to follow-up. So LTFU means loss to follow-up. So that means like not retained. So, and you can sort of see the precision and recall. And, what we really care about, like some of our models were predicting retention, but what we really want to predict is loss to follow-up, right? We want to know who is not going to be retained in care, and so that we can give them resources. So in the keep all notes one, for loss to follow-up, the precision was 0.3 and the recall was 0.248. So, not as good, but, predicting retention, which is a much more common, outcome, they were, higher precision and recall. All right, and these are some of the phrases that we saw, so that were associated with retention or non-retention. So in terms of phrases associated with retention, there were things like pregnancy, the words excellent adherence, PAP. So like if someone was coming in to get PAP smears or regular preventive care, that word was associated. Congenital HIV, so people who had HIV since birth, who've had a long history of having HIV. And then the phrase well on ART, I think, providers just write that. They're like, they're doing well on ART, like somebody's doing well. And then the phrases associated with non-retention. I mean, there were many, but these are just a few examples. So stigma, tearful, like if the patient comes in crying, the word substance abuse, the word K103N. So that's That's a mutation in the HIV virus, and is it's basically associated with resistance to certain antiretroviral therapies. So usually, if people have that mutation, often it's because they've been a non-adherent to their ART in the past and got resistance. Not always, but it can signify that, or the word syphilis. I've presented a lot of data about these, these models, that we've made, and, none of it, we're still trying to make them better, seeing what we can do. But then the other question is sort of like, well, say we develop a predictive model, like, is anyone even going to care? Is anyone going to even use it? So we did do some surveys with healthcare providers in Chicago, with 32 healthcare providers from 9 different healthcare organizations to say, like, if we use machine learning and develop this, fancy electronic tool to predict, retention or loss to follow-up from HIV care, what do you think? And so most people said that they would utilize a tool, 91%. So we were happy about that. But only about half thought that that a predictive model would perform better than their own personal judgment. And 53% thought it would be less biased. So some people thought the tool would be more biased, some thought it would be less biased. And we asked sort of, what are the major barriers that you would have to using a predictive model in practice? And one of the big ones was communicating the results. So they're sort of like, how would I... So say I could use it, but like, what am I going to say to the patient? How do I tell them, like, this is your risk for falling out of care? Like, I'm like kind of like, I don't really want to use it because I don't know how I'm going to talk to the patient about that. And it's going to be a whole conversation. They said time constraints, they don't have enough time to do that. And then they were also, we asked them, what do you think patients would think about this? And they were worried that patients might think the model was biased or discriminatory. And so that was another barrier that was identified. And so, in terms of, where we go next, so we actually currently have an R21 funded from the NIMH, the National Institutes of Mental Health, where we are trying to improve our NLP model. And we're, basically looking at different clinical phenotypes of people with HIV. So, using sort of this clinical phenotyping process, to identify within basically the idea that, one size fits all model may not be appropriate, right? Like there's definitely, there are young mothers with children who don't have childcare, and then there are like older, Latino men who have sex with men, and like maybe a model predicting, one outcome for both those different groups is not appropriate. And so we're sort of validating the model across different clinical phenotypes. And then we're also, it was so interesting that so many providers, only half thought the model would be better than their own intuition. So we're actually doing a study where we are comparing provider intuition. So we're giving providers, like, these are your patients, like, what do you think are the chances of them being retained in care in the next year? And then we're going to compare the results of the model versus the provider intuition and, reality, like what ends up happening in the next year. So I'm sort of excited to see the results of that. And then we also are planning to get patient perspectives. I think this is really an area where it's important to, really understand how people feel about it, how they feel about, I know there's been some work on this, but, and some work around, there are these models that predict, or, there's been some machine learning models predicting risk for acquiring HIV in people who are HIV negative. And, there's been some work trying to understand patients' perspectives around that. But no one's really, done the work to ask people with HIV how they feel about an electronic model, predicting their HIV outcomes. And then, ideally, we would actually, which we haven't done yet, is like create a tool, where we actually, show the results of the model into the electronic medical record sort of in real time for providers to use. And ultimately, hopefully doing a clinical trial where we see, if we implement such a model and use it, can we use that to actually improve retention and care for our patients, which is, ultimately the goal, right? So I do want to thank all my research team and collaborators, and thank you all for giving me the opportunity to speak. And I'd love to hear any questions that anyone may have.
Thank you, Jess. That was an amazing talk, and it's great to see where all this work has gone. When I was in Chicago, this was kind of in a much earlier stage, so it's exciting to see all the kind of iterations and the developments. So we want to open it up to questions. We currently have 2 questions in the Q&A. I also have questions of my own, and perhaps the other co-directors do as well. So Haley, is there an approach to this? Should I start with the questions in the Q&A?
Sure, go ahead.
Okay, sorry. I didn't mean to call you out on, anyway, okay. So, Jess, the questions that I'm about to read, I think are in reference to that first or second slide you showed, showing the, explaining the HIV care continuum. And so the question, it's 2 questions, but they're related, so I'm gonna package them. Is it okay to be virally suppressed, but not in care? I was a bit confused by that. And are they completely out of care, i.e. like not doing routine checks at the hospital for other things, or are they out of contact with HIV specific care? So I think it's a clarification on that.
Yeah, absolutely. Yeah, it is confusing, right? Because so that care continuum graph is like from the CDC and what they track. So yes, there are some people who are virally suppressed who aren't technically in care, and it depends on what measure they use, to be in care. And so I think the ultimate goal is to be virally suppressed, right? And so those people are taking antiretroviral therapy. So they may not meet the definition of in care, like having an appointment, 2 appointments within a year, more than 90 days apart, but they have a provider who's prescribing their ART, right? So again, some of the numbers are a little bit wonky, so yes, the goal is to be virally suppressed and to have a provider that you can reach out to, right? And so those people probably technically are, they might not meet the definition, but they really are in care because they're getting antiretroviral therapy. If that answers the question.
Yeah, I think so. Or this is a slightly odd format, but I'm hoping that answers the question.
Yeah. Yeah, and I'll say, in terms of whether they're seeing other, so they might be seeing other providers. So the way the CDC measures it is actually not based on visits. It's based on lab tests, because the healthcare system, healthcare facilities have to report viral load and CD4 count results to the Department of Public Health. And so they basically say, like, did you have an HIV viral load in the last year? And so whether that was with your primary care doctor, with, at a hospital, like all of that counts as in care. And so it's possible they went to like urgent care for another reason and nobody checked their viral load. And so that would not count as in care. But as long as a provider, ordered this lab test for you, you would be counted as in care.
Other questions from the co-directors before?
Yeah, hi Jessica. This was a wonderful talk. Thanks so much for joining us and sharing your work. So I was really interested with some of the future directions that you said at the end, especially about deploying this to be used in real time. So it seemed to me that it looks like you are using like at least you're hoping for the final model to really be the NLP model, right? The one that's based on nodes as opposed to on the structured fields.
I think so.
How do you expect this NLP model to run in real time over the nodes?
Yeah, that's a good question. That's a good question. I mean, I think so. It's so that may not be able, probably wouldn't be able to be run in real time, right? But I hope maybe you could do like a weekly refresh or something on the NLP model, right? And then give the results to the social workers and providers. There, actually within Epic, which is our medical record system, there is a model that Epic has out of the box that is like the missed visit chance. where they have a model. It's like, we actually published a paper where we, tried to look at it specifically for patients with HIV, and it's really not very good. But that they, validated and did, where it's like, this is your chance of missing a visit. And you can, pull it into the medical record and you can see it on your schedule. And so I think something like that, but that would probably need to be based on like structured data, right? That you could pull in and have that there displayed for people to use, but that we would, do with our data and with our patient population so that it performs better than sort of the out of the box EPIC model. But I think we need to do more studies to really understand, what is the best way to implement this, right? So we also asked providers, when we did that study where we asked them, the barriers, we asked, like, how would you want it to display? When would you want to know? And actually they wanted to know, they didn't necessarily want to know in real time. They wanted to know like the week before the patient's appointment, which actually might make more sense, right? So that then they could actually send more reminders for the patient to show up to their appointment, as opposed to waiting till the time that they came into clinic. So I think that's definitely still work to figure out is sort of the best way that this model could be used.
Yeah, that sounds very actually doable, right? So exactly running it kind of offline, but on a regular basis, and then having it ready for the doctors to look at it. And then the other thing, I guess, is that from my understanding and also because you're extracting a lot of this stuff with NLP, but just in general in medical records, a lot of the features will be missing.
Yeah.
Yes.
Right. So when you talk about linear regression, all these things, lots of those models don't allow for missing data. So do you have to like impute everything? And then if you're imputing, how do you imputing across different centers? Like I just like, as an ML practitioner, have a lot of questions about how this is doable.
I mean, oftentimes we'll use that as we'll just say like missing, include that as, like the fact that it's missingness itself we'll use, as the variable. And a lot of times, I don't know the right answer. Like maybe we should impute or just take in the fact that, honestly, in some of the other models we've done, just the fact that you have a lot of missing data means you're more likely to fall out of care. But it's sort of like, is it just
but linear regression
you don't have any data? Yeah.
So linear regression would not let you, even if you create like an extra variable that says missing or not missing.
Oh, yes,
it will still not let you have an empty field for when it's missing, right?
Right.
So it has to be doing something with the linear regression where it's like putting all the values to some.
Right. So we'll do some imputation, or we'll have to leave out variables where we don't where there's a lot of missing data, right? Which is a shame because, so many of the variables that we need the most are, there's a lot of missing data.
Yeah. Sounds good. Thank you.
So I have a question about the type of data you're using. So relying on, there's a wealth of information, albeit sometimes incomplete in EMR data. But the thing that I've been kind of, since my time in Chicago and during my postdoc, where I was kind of just learning all about this for the first time, is thinking through like, who gets left out of these models, which are people who are not in care at all. And, just between Jess and I, we know that the communities that Jess is studying, particularly in Chicago, and Black sexual minority men and trans women, is that they are not, they're probably the least likely to be tapped into routine care or any kind of care. So have you thought about other sources of data that maybe can be pulled into some of these models that might be able to fill in those gaps, or creating separate models explicitly with this in mind? And is a little self-serving, but are there like sources of informal health data, like digital epidemiology, and thinking through social media or other types of data that could be extracted to perhaps create to kind of get at these like social contextual factors that are that we know are really linked to HIV vulnerabilities? Just curious about this stuff.
Yeah, and it's so important. So we have done some work and collaborating with like the health department because, you know, they sort of are the keeper of data, and, you know, anyone who's diagnosed with HIV, they have data on, right? But it's very limited data. So yeah. So that gets around some of the sharing of EMR data. But again, yeah, you're missing a whole, you know, lots of data for a lot of people who aren't regularly engaged in care. We have, you know, we have done some work looking in Dr. Schneider, you know, our mentor's Facebook data to see if there are correlations with viral suppression, you know, people being virally suppressed based on sort of your social media, your Facebook network characteristics, number of friends and groups. We just didn't have that much data, you know, it was not that much, so it was not that illuminating. But there were a few features, you know, I think are surrounding like, you know, social, actually people who had more friends were less likely to be virally suppressed, I think, which is a little counterintuitive. But yeah, I mean, I'm super interested in that. You know, I think it would be really great to try to pull in those other data sources. I think it's challenging. You know, a lot has become, and rightfully so, there's a lot of, you know, caution around privacy and confidentiality and the ethics of, you know, especially around HIV, just because there is still so much stigma associated with that. And it is such protected health information in like bringing these other data pieces in. But I mean, I think that yes, I think, you know, including additional data is absolutely essential, and including patient reported data. You know, we're trying to do more where we you know, is because, you know, the health system, we're not great at asking at documenting stuff and asking stuff, but, you know, will patients tell us, you know, can we give them questionnaires that they can fill out, you know, through an electronic patient portal, or if they want to enter information to give us, you know, can we take that and to try to make the EMR more complete? But I agree with you that like, that, you know, most people live their lives outside of the health system, right? And so including different data sources, I mean, absolutely could be really important.
Yeah, I haven't quite figured it out either. Like, in the privacy thing definitely is like I'm going to say bottleneck, but I don't mean it in like I'm trivializing that. It's because it's important to countenance, but thinking through like best practices for drawing on some of these like publicly available social media data for these purposes in such a way that is not totally exploitative. Yeah, it's still something that I'm kind of grappling with too. Any other questions? I could continue on, but I also get to talk to Jess tomorrow, so I don't want to hog up time here. I think one thing I'd be curious just in the last couple of minutes, like you mentioned that social workers might, when thinking about the implementation of this in kind of a real world setting, that social workers might find this useful. And I've often thought about that too, because maybe it might be impossible to implement this in actual real time, like in a clinical setting. But given that there's often kind of a wraparound system of care that exists, have you, and just knowing the team that you're embedded in, which does include a lot of social workers, have you thought about trying to implement some, like kind of do a pilot where they might be able to have access to some of these kind of predictions so that they can give those appropriate nudges and kind of check-ins? I mean, particularly if you could, I see this being particularly useful for predictions of falling out of care or missing an appointment, right? Like, and there could be things that are just kind of going on in their lives, like that are kind of leading to this like slight disruption in care, like, but where the social worker would be that like an appropriate person to step in. And yeah, in my mind, that could be lagged, right? It doesn't necessarily have to be in direct real time, but they could kind of, I don't know. I don't know if that's even feasible given just how these systems of care are constructed and who gets access to what information, but I don't know if you have any thoughts on that.
No, I absolutely, I think that's a great idea. I mean, I think probably the social workers are, better, like, because a lot of HIV care clinics have social work teams, or a social worker. And, how they basically get referred patients, is just based on a provider mentioning something, or they meet with somebody and so they know about their, their needs. But I think having a real systematic way where we can be like, here's the list of people who really need, your help and, resources, based on, predictive modeling or, science and math, as opposed to just sort of a haphazard. I think that's a great idea. I think that's definitely, probably more useful than, going through providers, having providers refer for other resources.
Yeah. All right, well, I'll save the rest of my questions when we chat later. But we are right almost at 3 o'clock here. I want to thank Dr. Ridgway again for joining us, and thank everyone for attending. And I wish everyone a great rest of your day.
Thank you,
Great.
Jessica.
Thank you.
Thank you for having me.
Wonderful work.
Take care.
Yep.
Bye.
Talk later. Bye-bye.